You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. This is your host, Dr. Shawn McNeil. Today we're joined by Dr. Robert Sherrick, who is the Chief Science Officer for Community Medical Services. He has a piece in the July-August 2025 issue of the Journal of Addiction Medicine entitled Relationship Between Methadone Induction, Dosing, and Retention in Treatment in Opioid Treatment Programs. Well, Dr. Sherrick, I'm so glad that you could join us on the podcast, and I want to get started by having you talk to us and kind of explain to the listeners about your background in addiction, how you got started in the treatment of addiction, but also how you got involved in looking at addiction research.
All right. Well, my background is in internal medicine, trained at George Washington University a long time ago. And, like most people in training, and I think less so these days, but certainly back when I was doing it, there's really no training in addiction medicine at all. So I stayed on the faculty at George Washington for a few years, and then I moved to a small town in Montana in 1993. And I started working for a treatment program in 1994 that treated both addictions and it was a combined psychiatric co-occurring condition treatment program, inpatient. And at that point, we were treating all kinds of substance use disorders. And as an internist, I was working with the psychiatrist closely on dual diagnosis patients. And back then, we did not have any methadone at all in Montana. There were no opioid treatment programs. I started using buprenorphine when it became available in the early 2000s, and I incorporated that into my internal medicine practice. And then in 2009, I left the direct practice of internal medicine and moved over to VA Montana. And I started working for them half-time, and I started a buprenorphine program throughout Montana. At that time, I was the only person on the staff who was doing it. And we were an early user of telemedicine. Back then, now it's kind of common. Back then, it really was a new thing. So we used telemedicine going from one clinic to another clinic, and I was able to cover the whole state. And I left there in 2016, and that's when I became Chief Medical Officer for the company I work for now, Community Medical Services. I started working for Community Medical Services in 2010 when they opened their first opioid treatment program here in where I live in Montana. Worked as the medical director of that program for a number of years, and then took over as chief medical officer. And during the time I've been working for this company, we have expanded from about 6 clinics now up to we have about 70 opioid treatment programs, formerly in 2 states and now in 12. So it's been a very interesting and rewarding process for me to see more and more people get the treatment that they need. A couple years ago, I transitioned from Chief Medical Officer to Chief Science Officer. That's my current role, and it's in this role that I was able to do the background research and write up this article that we're talking about.
All right, thank you. Well, that is a great segue into this article. My first question is, what inspired you to start looking for these trends that you wrote about? Did you notice something that was maybe going on clinically that tipped you off to start looking for these trends? Or did you notice that treatment consistency just seemed to vary among the different providers?
Absolutely. Methadone's been around for, it was developed, the initial papers in the 1960s. And so we're talking about a treatment that's been around for 50 or 60 years. This is not new. In spite of that fact, we really don't have the science that we need in order to know what's the best way to dose people with methadone when they start out in treatment. There is a number of studies that show that the mortality rate, the overdose rate, goes up actually when people start methadone treatment, usually for the first couple of weeks, and then it starts to decline. And stabilizes then at a much lower level than it was before they started treatment. But that, of course, generates a lot of concern over this first 2 weeks and what is happening during those first 2 weeks, and why does the mortality rate actually go up as opposed to down. By the way, that mortality rate does not go up with buprenorphine. It starts going down right away once treatment is started. It's only with methadone that we see this. So the people have been wondering about that. In 2013, there was an article published in the Journal of Addiction Medicine called Safe Methadone Induction, and it was an expert panel that was convened by SAMHSA, and they were giving advice on how to get patients started on methadone. And as they looked at the data, there's really not a lot of data that tells us what doses work, what doses don't work. We have this data knowing that the mortality goes up, but we don't know precisely why, and we don't know what to do about it. The assumption was, and it's a reasonable assumption, but the assumption was that you really need to start with a low dose of methadone and go up relatively slowly just to make sure that we're not overdosing people on methadone. We're not giving them too much methadone. So the recommendations were, at that time, we were only allowed to give 30 milligrams as an initial dose, and then the recommendations were to go up 5 milligrams every few days, such that at the end of a couple of weeks, the maximum dose someone could be on was about 40 or 50 milligrams. And that was the advice, and I think many of us were following that for a long time. But then, particularly when the fentanyl era came out, we were looking at patients that had huge tolerances, and many of these patients were not stabilizing until they got to at least 100 milligrams or more. So we're using more methadone to treat. And we get concerned about the possibility of people, they're coming to the clinic every day and they're getting dosed, but after 2 weeks they're only getting 40 milligrams. That's only a fraction of what they need. And the concern is they could get discouraged, they could continue using street drugs, and it's possible that going too slowly could actually increase their risk of overdosing as opposed to decreasing it. Well, we don't have any data that tells us which of these two things is the case. So that was kind of the concern as we're scratching our heads, and myself as a chief medical officer and now as chief science officer, trying to give advice to all of our medical providers about what they should be doing with the methadone dose for the first week or two. I mean, obviously, it's going to depend upon the initial assessment in terms of what has somebody been using, how long have they been using, what's the route of administration, and what do you think their tolerance level is. So you're going to take all of those into account, but many patients are going to come in using huge amounts of street fentanyl intravenously for a long time, and we really need to figure out what's the best thing to do for these people. So we don't know that. This article was hopefully at least a little way of giving us some data to go on, as opposed to what we have now, which is mostly just death certificates and case series. So looking at the relationship between dosing early in treatment versus outcomes. And we're fortunate at the company I work for, we do collect a lot of data. So all of our patients, when we dose them, we know exactly what dose we gave them. We know when they got it. And so we have a very good and large data set that tells us how much methadone people are getting. And then we also know, of course, whether they stay in treatment, whether they continue dosing, or whether they drop out. So that was kind of the circumstances that led me to look at this particular issue.
Okay. So, also you mentioned that between different providers, there is perhaps a lot of variability in how the methadone is initially dosed or in how it's titrated. So do you feel that there are any trends that you really believe drive this inter-provider variability? And do you feel that providers with certain training or backgrounds are more likely to prescribe in a certain way?
That's a good question. I don't really know the answer to it. I mean, there is certainly variability from one provider to another. Part of that comes from the fact that we really don't have data that tells us what is really the right thing to do. What dosing regimen actually decreases a person's overall risk, mortality, overall outcome. The at the optimum level, the most amount. We want people to do is have the best outcomes possible, and we don't actually have the data that tells us what dosing regimen is going to do that as we approach people in the first 2 weeks. So there are some people who are going to interpret the data and decide that relatively lower doses are more appropriate, and other people are going to be more aggressive. And why people come down on one end of that spectrum or the other probably is a very individualized sort of thing, personal experience, just kind of your interpretation of the data and so forth. But suffice it to say that there are definite differences among medical providers, as some are routinely using higher doses and some are routinely using lower doses during the first couple of weeks.
Great. Well, I wanted to talk about the limitations of this study, which may help drive some discussion about areas for future research. So what do you feel are the biggest limitations, and what areas do you feel need to be pursued more in the future?
Well, of course, the best gold standard research study would be to do a randomized study, even blinded, but it's really not possible for something like this. So we end up having to rely upon observational data, like this study, where we have an observation. We looked at all the patients. We excluded patients who didn't meet certain criteria, and particularly we only looked at patients who came in and got a dose every day for the first 7 days, because we didn't want, if people were missing doses during the first 7 days, they didn't want that to affect the dose they finally got to on day 7. But it turns out that most of the patients were coming in all 7 days during the first week. And we just compared the dose they got to on day 7 versus their chances of staying in treatment by day 30, and found out that there was a strong relationship. So higher doses at day 7 were associated with better retention at day 30. Now, one of the limitations, of course, of a study like this, it's an observational study. It doesn't prove causality, but it does show at least a statistical association.
All right. And you mentioned, too, that looking at the mortality data may give us some specific insights into whether or not certain titration regimens are more beneficial.
Just about to say that. Yes, I was just about to segue into that. Yeah, you're a step ahead of me. There we go. Another thing this study can't look at, I mean, it did look at retention, 30-day retention. And obviously, we believe that staying in treatment is a good thing. We know that from other studies that people who stay in treatment have a lower risk of overdose and death, and they have better outcomes in terms of social determinants of health. So staying in treatment is a good thing, so we know that. But what we don't know, and what this study can't measure, is what about this increased mortality during the first 2 weeks? Does going up on the dose, getting to a higher dose by day 7, is that dangerous at all? Is that dangerous in terms of potentially increasing the risk of an overdose in the first 30 days? And this study can't do that, but it would be wonderful to have if someone could put together enough mortality data. And it takes a lot of data to do this study because fortunately deaths during the first few weeks of treatment are relatively rare, but they do occur. But with enough data, we hopefully would be able to answer the question, what is the relationship not only between initial dosing and retention, which this study attempts to address, but what is the relationship between initial dosing and mortality?
Okay, well, I think it would be fantastic, and I'd be interested to see the results of that. Now, as a clinician, and just because I like to always ask before we finish, I would like to see if there are any specific clinical pearls for our listeners who maybe they're providers and have patients that may benefit from some of the findings from this paper.
Yeah, I think there is getting to be more and more research and more looking into this topic. And I think it's a really important topic for people coming into treatment. We really need to have better science as to what is the right dose for people. Now, there's some trends that have been going on. One is that the SAMHSA has changed the rules with a new final rule coming into effect about a year ago, allowing us to start at 50 milligrams routinely as opposed to the previous limit, which was 30 milligrams. And then there are also cases where you can go above 50 milligrams for the first day's dose. SAMHSA and the regulations don't say anything about subsequent doses. So the trend has been, I think, with using higher doses and going up more rapidly in the initial phases of treatment. There's a number of people who have been experimenting with that, mostly in inpatient settings, because that's a place where people can be monitored very closely, and you can determine if someone is getting excess sedation or seems to be at risk for getting an overdose from the methadone itself. And many of those studies are showing that people can be taken up to higher doses more rapidly, and they're getting good outcomes. So I think there's probably a trend in that direction, but for now, I don't think we really know where that's going, and we don't know for sure what we should be doing for outpatients as opposed to inpatients. So I think a lot more study on this is really going to be helpful. It's going to help those of us who are in the trenches, who are working with these patients every day, and trying to help them as best as we can.
All right. Well, I want to thank our guest, Dr. Sherrick, for being on the podcast today. His article can be found in the July-August 2025 issue of the Journal of Addiction Medicine. Again, it's titled Relationship Between Methadone Induction, Dosing, and Retention in Treatment in Opioid Treatment Programs. Thank you for joining us.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.